Bismillahirrahmanirrahim. First, I'd like to welcome you all. It is my pleasure to meet you again in the second webinar. In the first webinar, we discussed the linear examination of the from the abdomen and different stations 1, 2, 3, 4, and examination of the liver. In the second webinar, we will repeat the examination of the liver because it is very important, and we will discuss the linear examination of the mediastinum from the esophagus and give a small hint or throw light about rectal examination and the different pathologies in the liver, mediastinum, and rectum. Now, let us start our lecture today. In less than 1 hour, we will start by liver examination. Now, to start the liver examination, our landmark, as I mentioned in the first webinar, is the inferior vena cava, the uppermost part of the inferior vena cava at the right copula of the diaphragm. So this is our start point in examination of the liver. We locate the echo endoscope at the cardia, 40 centimeters from the dental arch, and start to do clockwise and anti-clockwise to find this landmark, the inferior vena cava. Sometimes we find the abdominal aorta as a longitudinal structure. Okay, this is a very nice another landmark. By then we do anti-clockwise rotation for 90 degrees, and then we will find the inferior vena cava, the uppermost part of the inferior vena cava. Then we will start examination of the liver. This is the inferior vena cava, uppermost part, and this is the intrahepatic part of the inferior vena cava, and this nicely seen right hepatic vein. Why it is the right hepatic vein? Because it is a sloping vein, as I mentioned before. The widest diameter is at its insertion in the inferior vena cava, and then there is gradual decrease in diameter, gradually sloping when it goes deep in the liver tissue away from the echo endoscope. So this is the right hepatic vein, very nicely seen, and this is the inferior vena cava, and this is the insertion of the right hepatic vein into the inferior vena cava. So here we have 3 segments of the liver. The segment in between the echo endoscope and the intrahepatic portion of the inferior vena cava is segment 1, the caudate lobe, and the segment in between the IVC and the right hepatic vein is segment 8, and the segment below the right hepatic vein is segment 7. So this is 1, 8, 7. 1, 8, 7. And then we will start to do anti-clockwise rotation, gradual anti-clockwise rotation to go to the middle hepatic vein. Still now we are seeing, yes, this is very nicely seen middle hepatic vein. Middle hepatic vein is unlike the right hepatic vein. It has a homogeneous diameter, that its diameter is the same from its beginning to its end. It is a long vein going to the inferior vena cava. Here at the level of the, here at the level of the middle hepatic vein, we find here, yes, we are going to the middle hepatic vein now. This is the right hepatic vein. We are now going to the middle hepatic vein. Yes, very nicely seen middle hepatic vein. Here we can find a fibrous structure above the middle hepatic vein, joining the left portal vein to the inferior vena cava. This is fibrous structure is the ligamentum venosum. So in this view, we find the middle hepatic vein and the ligamentum venosum. Here the segment of the liver, yes, this is very nicely seen, ligamentum venosum. Here the segment between the echo endoscope and the ligamentum venosum is segment 1, still the caudate lobe. And here the segment is 4A between, 4B, segment 4B, between the left portal vein and the inferior vena cava, ligamentum venosum, and the middle hepatic vein. And this segment is segment 8. So this is segment 1, the caudate lobe. And this segment is segment 4B, and this is segment 8, okay? I will keep anti-clockwise rotation, more anti-clockwise rotation. I find the left hepatic vein. So I start with the right hepatic vein, and anti-clockwise rotation, I find the middle hepatic vein and the ligamentum venosum. And more anti-clockwise rotation, I find the left hepatic vein. And here is segment 2 and segment 3. Here segment 2, very well seen. And here I can do hepatico gastrostomy, EUS guided biliary drainage. If I choose segment 2, I can do it from this view. So this is very nicely seen left hepatic vein and segment 2 and 3. This is another video showing the same segment, but here I will add something. But let us start. Our starting point is the inferior vena cava at the right copula of the diaphragm, and this is the intrahepatic portion of the IVC, and this is the right hepatic vein. So segment again, 1, caudate lobe, 8, 7. 1, 8, 7. Then I will do gradual anti-clockwise rotation. I am repeating again and again. Anti-clockwise rotation. This is the right hepatic vein, IVC 1, 8, and 7 segments of the liver. Then I will go to in the anti-clockwise direction to see the middle hepatic vein. Yes, very nicely seen middle hepatic vein. And this is the ligamentum venosum. And so this is segment 1 and segment 4B and segment 8. 1, 4B, and 8. Here in that video, I will add something. I will push the endoscope inside the patient few centimeter, 1 centimeter by 1 centimeter, to go to what is known as fish eye appearance. To go what is known as fish eye appearance. Yes, this is the classic fish eye appearance. The fish eye appearance, yes, this is the classic fish eye appearance. The fish eye appearance is the left portal vein, left portal, not hepatic, left portal vein. Very nicely seen, the fish eye appearance, like the eye of the fish. And from the fish eye appearance, I can find 2 fibrous ligaments. The first one is the ligamentum venosum, which we have already mentioned, ligamentum venosum going to the inferior vena cava, and to the left side of the screen is the ligamentum teres, going to the anterior inferior aspect of the liver. At the level of the fish eye appearance, at the level of the left portal vein, I find here segment 4A and 4B. Here 4A and 4B. At the level of the ligamentum teres, here segment 3 and 4B. At the level of the ligamentum venosum, as I previously mentioned, this is segment 1 and segment 4B. So this is segment 3, 4A, and 1 caudate lobe, and here is 4B, 4B, 4B. All this area is 4B. So this is a very nice landmark, which is a fish eye appearance, left portal vein, and the segments here are 3, 4A, 1, and 4B, 4B, 4B. Okay, and here segment 3, I can do also EUS guided biliary drainage from segment 3. If you noticed, I mentioned all liver segments in the previously seen 2 videos, except segment 5 and segment 6. Segment 5 and 6 are related to the gallbladder. Segment 5 is at the neck of the gallbladder here, and segment 6 is at the fundus of the gallbladder. How I can get this view, the gallbladder and segments 5 and 6. The gallbladder, the most nice views of the gallbladder is at the bulb of the duodenum with anti-clockwise rotation of the tip of the echo endoscope to face 9 o'clock, to face the anterior wall of the bulb. Or in the antrum, just before the pyloric ring, in the pre-pyloric area, and also looking to 9 o'clock by doing anti-clockwise rotation. Here or there, I can find the gallbladder and the liver. So, nicely seen, this is the gallbladder, seen from the bulb of the duodenum, and this is the liver tissue. This is the neck of the gallbladder, and this is the fundus of the gallbladder, and this is segment 5, and this is segment 6 of the liver. So we saw nearly all segments of the liver. And I should highlight that we should see the liver thoroughly during EUS examination, especially in cases of staging of pancreatic and gastrointestinal malignancy. In cases of pancreatic or gastrointestinal malignancy, whether esophagus or stomach, because sometimes I can find small hepatic focal lesion, likely metastasis, not seen by CT or MRI, and this will change the line of management of the patient from resectable tumor major surgery by Whipple or distal pancreatectomy or so on to palliative chemotherapy. So it is very important to examine the liver in every case. To my mind, I examine it in every case, but especially important to examine in cases of staging of gastrointestinal, esophageal, gastric, or duodenal malignancy or pancreatic malignancy for possible liver metastasis, changing the management of the patient. Let us see some pathology in the liver. This is liver, and I find here that there is a very nicely seen malignant looking mass. Yes, this is very nicely seen malignant looking mass, very clear. And here we can see, and here we can see nicely the fish eye appearance. Yes, this is the liver, and this is a fish eye appearance. Yes, this is the fish eye appearance. Yes, this is the left portal vein, and this is the ligamentum venosum going the IVC, and this is the ligamentum teres going to the left side. And as I told you before, this at the level of the ligamentum teres, this is segment 3 and segment 4B, and this is segment 4A and 4B, and this is segment 1 and 4B. So this is located exactly at segment 4A. Yes, this is fish eye appearance, very nicely seen, and it's just above the left portal vein. So this is segment 4A. So it is a metastatic liver disease, a segment 4A in a patient with cancer head of the pancreas. This is another large focal lesion of the liver. This is the left hepatic vein going to the inferior vena cava, and this is segment 2, segment 3, and this is the left lobe of the liver. And we notice that starting appear here a hyperechoic structure, hyperechoic mass encroaching upon segment 2 and 3. Actually, it is a very large mass. It's about 6 or 7 centimeter. Yes, a very large hyperechoic mass. The patient is well built, no loss of weight, no significant clinical implications, with a very large hyperechoic mass located in the segment 2 and 3. So most probably this is a large hepatic cavernous hemangioma, and we notice here that there is a smaller one. This is a large one, and this is a smaller one. Where it is located? It is located, yes, in segment 3, because this is the fish eye appearance, and this is segment 3, 4, 1, and 1, caudate lobe, and this is segment 4B, 4B, 4B. So the large one is located in segment 2 and 3, and the smaller one is located in segment 3 above the ligamentum teres, and this is the classic fish eye appearance. This is a case of cancer head of the pancreas with multiple hepatic focal lesion occupying nearly the whole segment of the liver. This is the left hepatic vein, segment 2 and 3. There are multiple hepatic focal lesion, highly impressive of liver metastasis. Not only that, we can use our own weapon during endoscopic ultrasonography examination. I like so much using the elastography, real-time elastography, especially in hepatic focal lesion. Why? Because in hepatic focal lesion, especially in metastasis, metastasis occurring in a normal healthy liver. The normal healthy liver is so soft, and the metastatic lesion is very hard. So the difference is very clear between the two. The pathology, which is the liver metastasis, and the normal liver. So here elastography is very accurate. As you see, this is the area of interest, this is the window, and this is a focal lesion. This is split, the screen is split by two identical pictures. This is the focal lesion, this is the same picture. And here we notice that the metastatic lesion is very, very, very well defined by its blue color, which denoting hard consistency, while the normal liver is very soft, colored by red, yellow, and green. And this may be somewhat very important because it can differentiate it from other benign soft lesions like hemangioma or focal fat deposition, depletion, or deposition. So mostly it is a malignant mass. Not only that, I can do very simply FNA from all segments of the liver. Very easy to take FNA from any focal lesion in the liver, apart from 5, I think 5 and 6 somewhat difficult because there is intervening gallbladder in between the echo endoscope and segments 6 and 5. But here, this is a lesion located in subdiaphragmatic area, somewhat difficult or somewhat dangerous to be taken by percutaneous route, whether by ultrasonography guided or CT guided. Here the diaphragm and here's the heart, so somewhat difficult. It is the dome of the liver, so it is difficult or dangerous to be done by percutaneous route. But here during endoscopic ultrasound, it's very easy, very safe. I enter through a liver tissue and monitoring throughout the whole course of the needle. Here I can take very simply, this is a focal lesion of the liver. Here I can introduce the needle and controlling it, and not to push it to bypass and go to the diaphragm and the pleura and the lung. It is moving only inside the hepatic focal lesion. So it is very nicely, I can do it very safely and very nicely. FNA of hepatic focal lesion. This lesion is very easy to take in, although it is away from the echo endoscope, but its course, the course of the needle, is very safe, no intervening important structure.